So next, we're moving into multiple myeloma and what you need to know. Thank you to our gold sponsor, the International Myeloma Foundation and the Empower Initiatives for supporting this session. Our speaker is Dr. Joseph McHale. He is a professor at the Clinical Genomics and Therapeutics Division at the Translational Genomics Research Institute, an affiliate of City of Hope Cancer Center. He also serves as Chief Medical Officer of the International Myeloma Foundation and leads myeloma research at the Honor Health Research Institute. Dr. McHale is a global leader in myeloma care with more than 200 publications and a strong commitment to reducing disparities through the Empower Project. Give it up for Dr. Joseph McHale.
I don't get that kind of introduction every day. It's so nice to meet every one of you here today. I am just so touched by this whole summit, the expo. This has just been fantastic, right? There are any New Yorkers in the room, you know, they always say, am I right or am I right? I'm right. So I want to talk to you for the next few minutes about a disease that some of you may have never heard of, and some of you, sadly, potentially have heard about it in your family. Let me just ask right off the start, how many people have heard about multiple myeloma? Okay, how many people have not heard about multiple myeloma? All right, so if you've heard about myeloma or you've never heard about myeloma, this talk is for you. Before I get into that, I want to start with something simple. This is meant to be, if you will, a little bit of a lecture. I'm not trying to scare you. I'm not giving you like PTSD from 7th grade or anything like that from science class. But let's start by talking about our blood. So what is the blood? Now, you heard the introduction. I'm a blood doctor. I'm a blood cancer doctor in particular, so I'm a little bit obsessed with the blood, like not vampire obsessed, but I'm obsessed with blood. But people don't often think that blood is actually an organ. When you think of an organ, you think of the heart and the kidney. I mean, no disrespect to the people talking about hearts and kidneys today, but without blood, they're useless, right? So blood is a vital organ to the whole of the body, and it's made up of two things. I'm going to make you blood doctors in the next 6 minutes. Listen up. It's made up of two things. It's made up of the liquid stuff that we call plasma, and it's made up of the solid stuff that we call cells. And there are three kinds of cells in the blood. I recognize we are in the house of the Lord, but the Lord made water into wine. So we're going to use a wine analogy here, right? You have three kinds of cells that circulate in your blood, just like wine: white, red, and rosé. Okay, so I usually don't get that much of a laugh from this. This is good. I like this group. So think of the red cells. These are red cells that circulate through your body. They pick up the oxygen that you breathe in, and then they deliver it to the tissues. So I say that red cells are just like little red trucks. They pick up oxygen, go to the brain, drop it off, go to the kidneys, drop it off, go wherever they go, drop off the oxygen, come back and get more, right? Simplifying things for you. White cells are different. White cells are like soldiers in an army that are meant to protect you. Interestingly, we have 5 kinds of white cells, kind of like we have, if you will, 5 major branches of the military. And so these are different kinds of cells. And we're going to come back to those white cells in a moment because they're particularly important when we think about multiple myeloma. And number 3, you have these little cells. They're not really rosé, but I call them rosé cells. These little cells called platelets. And platelets are the little things that help you clot. I think of them as kind of like the ambulance. They're the first ones on the scene. If I get a cut in my hand, the platelets get there first. They kind of plug up the hole. Then they make a phone call to what we call factors that really form a strong blood clot. So when people have things like hemophilia, they're missing the factors. But even before the factors, we need to get the platelets there first. So these 3 cells right now, while you're listening to me, I'm sure a lot of your cells are making their way to your stomach to digest that bread that we just ate. Of course, Deshaun told us that bread comes from Satan, but I actually like bread. Yeah, I love you too. But some of those cells that are circulating in your blood right now, they're doing exactly that. They're picking up oxygen, dropping it off. They're defending you from any potential infection that you might get, and they're making sure that your blood continues to flow and that you don't have any bleeding. Well, where are these cells made? They're made in the factory of our blood, what we call the bone marrow. So when we talk about blood cancers, we're typically talking about cancers that start in the factory of our blood. You know, I tell patients, when we have to do a bone marrow test, it's like going into the factory. If there's a car factory here down the street and I see the cars that are made off of it that come off the assembly line, that's pretty good. But if I really want to understand the car factory, I've got to go inside the factory. So when we go inside the bone marrow is where we see the factory of the blood. So why are we talking about blood? Well, we're talking about blood because there are some unique features about being Black that are very important for us to understand when it comes to the blood. Initially, people tend to think about something like sickle cell disease, which is often the first thing people think of when we talk about blood diseases that affects the Black population. And it's not a perfect picture here, but imagine these little red cells that I told you pick up oxygen in the lungs and go deliver them to the tissues. If they're not shaped in a certain way, they're not going to be able to get through all the network of the vessels of the body. And that's essentially what happens in sickle cell disease, is that those nice round red cells now become the shape of a sickle. And that causes lots of trouble. It doesn't deliver the oxygen properly. They can clump up together and cause blood clots. They can clump up together and block off good oxygenation to tissues and cause pain crises and all sorts of other things. So I'm not here to talk to you much about sickle cell disease today, but I want to get you to understand the importance of blood as we talk through it. The other interesting feature that happens within Black individuals is our white cells, which is a little bit ironic, but we'll come back to that later. So, for those of us born in Africa or from African descent, and this picture just shows you where it's more concentrated than not. I'm from northern parts of Africa, but you can see here in the midsection of Africa, it's most common. It's common for people to have a lower white blood cell count. And it's actually only been in the last 3 or 4 years that we've discovered what this is called, something called the Duffy null associated white count. You don't have to worry about the name of it. But why this is so important is that for years, often Black individuals were told, oh, your white cells are a little bit low, you know, you're going to be at risk of an infection and that's going to be a problem. Or often we're going to come to talk a bit about clinical trials later and different treatments that we give. It would disallow people to go on to certain treatments because they would say, oh, your white count is too low, you're at too much risk of an infection. When in fact, we've discovered that even with that lower white cell count, you're just as protected against infections as those with the higher white cell count. So it's another example of how historically our community has been not given optimal treatment because of something that is not well understood. And that is partly what brings us now, of course, to the concept of multiple myeloma. Multiple myeloma is a cancer of a different cell that lives in the bone marrow, one of the white cells that live in the bone marrow, and it's called the plasma cell. Now, most of you probably haven't been talking about plasma cells much, but believe it or not, we talk about plasma cells all the time, we just don't realize it. Every time you get a vaccination, every time you get an infection, your body responds. So what happens when you get that flu shot or the COVID shot or whatever shot it might be? That sends a message to your plasma cell. You get an infection. You're a little kid playing in the sandbox, playing out in the backyard here in beautiful Atlanta. Your body gets exposed to something. It sends a message to the plasma cell, and the plasma cell says, we want to be protected from this. And it creates what we call an antibody. Now, as you all know, in medicine, we love to use words that patients don't understand. So we call them immunoglobulins, right? But basically, these are just antibodies, and these antibodies protect you. If it weren't for your plasma cells, you wouldn't be alive in here today. So I'm a plasma cell doctor, I get it. I love them maybe a little too much, but plasma cells are so important to us. Myeloma is a cancer of the plasma cell. So instead of the plasma cell making good antibodies that fight off infection, now these antibodies are actually bad for you, and they go and start attacking your body itself. So it's not just that you have, when I think of cancer, what's cancer? If you had to define cancer in a few words, what would you say to someone? I say it this way: cancer is identical, uncontrolled growth. It's just easier to picture a lump of breast tissue or lung tissue or colon tissue. But here it's the same thing. These plasma cells, instead of growing in the normal way, making good antibodies, now they grow out of control and make bad antibodies. And what happens is they cause this thing that we give an acronym to CRAB. They can increase the calcium in your blood. They can damage your kidneys. They can lower the red cells in your tragedy. They can reduce that red blood cell count so people can be anemic. Someone was just talking to me at the break saying, my doctor said I was anemic and now they're going to be testing me for myeloma. That's an important test to do. Or most importantly and sadly, they can attack the bone. And that's how we remember what myeloma does to the body. Now, the reality is lots of other diseases can cause these signs and symptoms, which is why often the doctors don't think about myeloma, because myeloma, the diagnosis can be very challenging. How do people typically present with myeloma? They come in because they're fatigued, they have back pain or bone pain, or if they do get a blood test, they're anemic. Now, who in this room has not at some point been fatigued or had back pain, right? I mean, we all do. It doesn't mean you have myeloma, but you can understand how hard it is then to come to the diagnosis. And I'm going to share with you in a moment that typically the diagnosis takes 6 months to make. Do you know that the average patient sees their primary care provider 3 times with signs and symptoms consistent with myeloma before the diagnosis is thought of? And that is almost 6 months longer in African American and Latino Americans in the United States today. That's why I'm standing here. That's why we want to shorten that time to diagnosis. Now listen, I don't want you to leave frightened today the next time you have back pain, the next time you're fatigued, that you have myeloma. So don't be obsessed with it, but at the same time, this isn't just the usual fatigue. This is fatigue that is persistent, that is really out of keeping. The kind of fatigue that makes you scratch your head and saying, there's something not right here. This is the kind of bone pain that's not just, okay, I woke up on the wrong side of the bed, or I did too many of Deshaun's exercises and now I'm a little bit sore. Yeah, I love you too still, brother. Don't worry. And I'm a little bit sore. This is pain that, and I don't mean to make light of it, but this is pain that is persistent, that is really not making sense. Or people say, okay, well, they tried this and they tried this pain medication or even some physio, or tried these different things and it didn't get better. So it tends to be the severe version of those. Now, myeloma is not common. It's about 2% of all cancers. But as I'm going to explain to you, it's considerably more common in those of us of African descent. In fact, it's twice as common for us than white individuals within the country. And so that's why it's very important for us to talk about the disease today. Now, when I started in myeloma 25 years ago, most patients lived about a year. One of the reasons why I went into myeloma is that I wanted to treat the sickest of the sick. Thankfully, now that has dramatically changed. In fact, it has perhaps improved as much as any cancer that we have. With all these new treatments, all these exciting things you hear about, myeloma is really at the forefront of it, because now the average patient's going to live over 10 years, and many of our patients are living even much longer. And more importantly, they're not just living longer, they're living better, as we have better treatments, less of the bald and barf chemotherapy and more with real treatments. And we're getting closer to the cure than ever. The mission that we have is to find this cure for multiple myeloma. And we're working so hard at the International Myeloma Foundation towards that cure. And some of it, and I don't have time to go into a lot of detail today, but some of it involves some of these incredible new therapies. You may have walked past some of the stations outside here, where one of them, for example, is called CAR T-cell therapy. Who's ever heard of CAR T-cell therapy? Yeah, it's not very well known. And again, let me make you a cancer doctor in 45 seconds. CAR T-cell therapy is where I take T cells out of you. T cells are like soldier cells that you have in your body. And basically, I train these T cells to know what your cancer looks like. And then I give them back to you. And these amped up Rambo soldiers are itching to go after your cancer, and they go and get it. We do this in multiple myeloma. The response rate to this is over 95%. We've never had any kind of treatment that is as exciting and as impactful as things like CAR T-cell therapy. So when we talk about myeloma, I don't want us to talk about it as a death sentence. I want us to talk about it as a disease where we have access to these amazing therapies, which unfortunately brings me to the concept of health disparities that you all know. One of the reasons why my dear friend here has started Black Health Matters and leads the great work that is being done here is because we know what disparities are. And I don't have to make these definitions for you, but this is preventable. This is keeping us from experiencing our optimal health. And if there is any cancer that has a disparity, I'm going to make the case over the next couple of minutes to you that sadly, multiple myeloma is the most disparate cancer within the Black community. Meaning that a Black man or a Black woman diagnosed with myeloma today is expected to live half as long as a same-aged white man or white woman. That is entirely and absolutely unacceptable. And our goal today is obviously working towards health equity to reduce that. So what are these facts that are driving what we're thinking? Well, as I mentioned already, one is expected to live half as long as the same aged white man or white woman. And yet we're at twice the risk of getting multiple myeloma, as I noted earlier. Not only that, African American patients and Latino American patients actually are diagnosed at a younger age. You know, when I went to medical school, we were sort of told, yeah, myeloma is a disease of the very elderly. You know, don't really think about myeloma until someone gets to 65, 70, 75. You know, I had an African American woman in my clinic this week, 28 years old with multiple myeloma. And she was sent from doctor to doctor. They thought that she was faking her rib pain and looking for opiates when in fact she had cracked ribs because of multiple myeloma. So we need to recognize that myeloma presents differently. As I've already commented already, there's a longer time from the symptoms that people have to the diagnosis. And that's part of my goal today, not to make you afraid of those symptoms, but if you are experiencing some of those symptoms, that you talk to your doctor about it so that we can get to the bottom of it so that there isn't a delay. One of the greatest disparities, one of the reasons why we see that big difference in survival between populations in the US is really about access to treatment. And I don't have time to tell you about all the treatments we have today, but sometimes I summarize the treatments we have in multiple myeloma, 4 things that all start with the letter T. One is transplants or bone marrow transplant or stem cell transplant we've been doing for years. Number 2 is triplets or 3 drug combinations. We've learned when we combine drugs together, patients can do better. Number 3 are clinical trials. I'll come back to clinical trials in just a minute. And then lastly, CAR T that I just explained to you. You're all CAR T experts now, right? You know what CAR T cell therapy is. When I look at all 4 of those therapies historically that have improved survival in myeloma, I can demonstrate to you that Black Americans have had less access to all 4. So we want to work towards reducing that and ensuring that everyone has access to all the therapies. Now, some might say, okay, well, maybe Black patients don't do as well with myeloma because they have more aggressive disease. There are some cancers where if you're Black, you're more likely to have a more aggressive form of the cancer. Do you know that's the opposite in myeloma? So in myeloma, Black patients are less likely to have what we call high-risk myeloma. We divide myeloma into standard risk and high risk, but 25% of patients have high risk. You're less likely to have high risk. So the disparity is even greater. Lastly, and perhaps importantly, and maybe a little bit uplifting, because these last few statements haven't been the happiest things I've ever said in life, but let me uplift you a little bit that we know through studies like in the VA, where at least theoretically, people are given, independent of race or background, they're given the same access to diagnosis and treatment. We found that within the VA system, African Americans with myeloma live just as long, if not longer, than their white counterparts with multiple myeloma. So when you get the right diagnosis, when you get the right therapy, it can improve outcomes for sure. What drives this? You all know this. You know, sadly, what affects our health: systemic racism, the way the healthcare system was designed and run, the social determinants of health. I try to tell the residents and fellows who work with me all the time, you can have the greatest spiel about your treatment, about your clinical trial, about your CAR T-cell therapy. If that person's hungry, they're not going to hear you. And so we have to address the social determinants of health. But these in red are the ones that I've been mentioning that are related to multiple myeloma. One of the things that we have a challenge with, for some of you who know some of the signs and symptoms of myeloma, they often overlap with diabetes. And so when in the Black population, in the Latino American population, where diabetes is more common, often people are told, oh, that anemia, that's your diabetes. That kidney issue, that's your diabetes. That neuropathy you're having, oh, that's your diabetes. When all along they have multiple myeloma. And so diabetes can be a great mimic. The delayed diagnosis, the access. And then, of course, let me put some of it on us as providers, that we have not provided optimal therapy to all patients. And I'm going to show you how we're trying to address that in my last few minutes here. Part of it is a program that I had the privilege of creating, and some of my colleagues were here out at the table sharing some good merch and pads with you. My wife thinks I have an addiction to paper pads. So you better take them all before I get back out there. We created this program called Empower. It was a little play on words, to empower patients and communities to change the course of myeloma. And we did it with three things. They all start with the letter E to help me remember them. One, to engage the community, just like this, to tell you about what myeloma is so you can understand it, so you can be aware of it, so that you can know what those signs and symptoms are, so that if you have a loved one or someone with myeloma, we're here to support you. We're here to help you through that journey. Number two, to educate the primary care world so that diagnosis can be made more quickly, so that those primary care doctors think about myeloma when you have that back pain, when you have that anemia, especially if you're Black, because your risk is higher. And then number three, to enhance the care that patients get. Teaching the doctors, the nurses, working with the healthcare system to be able to provide access to these key treatments that we've talked about. We've done this nationally and locally. The idea here is we want you to leave today empowered, that you know the signs and the symptoms, that you speak to your doctor if this is happening, that you share this with your community. And so we've had the privilege of partnering with some people, you may know this guy here, who's worked with us, where we had him doing public service announcements on the NASDAQ screen in New York City during Black History Month last year to raise awareness so that people can understand how this disease affects your community. We do programs always in New York City around Juneteenth at churches, much like this church here. We did a program recently with a group of wonderful individuals in Philadelphia, and we had a patient, and I get to end with this in just a minute. We had a patient herself who had been on a clinical trial to share her story. You know, she sat in front of this crowd of about 250 people in Philadelphia and said, my doctor said to me, I think you should go onto a clinical trial. And she said, before I knew it, I had my hands over my ears and I said the word Tuskegee to him. She said, I didn't even know that I was going to do that. But then she took time and she thought about it and she listened. And she said, I'm here today because of that clinical trial. And I'm not here to convince anybody into a clinical trial. I'm here to say there are options, and sometimes the best option might be a clinical trial. So we have the privilege of doing these workshops. You can go to the Empower website if you want at myeloma.org and learn a little bit more about it. And part of it was this program that I've mentioned, where we've taken patients and even their care partners who have been on a clinical trial to share their story. You know, it's one thing to hear it from Dr. Joe. It's a much better thing to hear it from a patient, to see what they've experienced through this. And then lastly, I'm going to close by telling you that we've created arguably my favorite program, where we've taken medical students, mostly from historical Black colleges and universities. We've paired them with a myeloma expert to do a project in health disparities, and we gather every year at the annual meeting of the National Medical Association. I'm sure you're familiar with the NMA. The NMA was a medical association created over 120 years ago when Black physicians were not allowed in the American Medical Association. And these physicians come together every year to raise awareness and to discuss health disparities. And these students come together. They're amazing students, and they share their work together, because my goal is that these students, the future of our healthcare, the future is going to be brighter when they understand their community, when they understand health disparities. You know, 14% of the population is Black, 6% of physicians are Black, only 3% of oncologists are Black. And so we want to work towards encouraging them in a field of oncology. So as I come to my conclusion here, I've shared already with you, health disparities are more dramatic in myeloma than just about any other cancer. Although myeloma is not curable yet, We're getting there. People are living longer and better. And the Empower program was designed, as I mentioned, to engage, to educate, and of course, to enhance the care. So what do you do today? What do you leave today? If you've been napping because you had 2 Subway sandwiches, wake up for this last 20 seconds here, right? These are the take-home messages for you. Myeloma affects the Black community more than you might know. You actually probably know someone with myeloma. They may not just have told you yet. Be aware of those early signs and symptoms, that pain, that fatigue, that anemia that doesn't make sense. We're here to support you through that journey and the marvelous support that you have here at Black Health Matters. And I really believe that we can do something to improve our community. So thank you so much for your attention today. I believe we have a little bit of time for Q&A. So if you have a question, we have some wonderful mic runners here.
What is the common age for diagnosis? Most common?
So in case you didn't hear the question, an excellent question, thank you. What is the common age? The average age of diagnosis, if you look at everyone with myeloma, is about 69. Within the Black population, it's about 64 to 65. The range, however, is huge. It almost never happens under the age of 20. About 3 to 4% of people are under the age of 40. So the most common age or range of diagnosis of myeloma are people in their 60s and 70s.
What is myeloma? What is it? What disease is it?
Well, it is a disease of that plasma cell, those cells that live in our bone marrow that make antibodies. They become cancerous. They grow out of control. You know, one of the things I didn't really get into a lot of detail is, honestly, we don't know what causes multiple myeloma in the vast majority of cases. We know a few things put people at risk of myeloma. As I mentioned, just being of African descent puts your risk twice as high. But there are people who have had certain exposures, are veterans who have been exposed to Agent Orange, firefighters who have had repeated exposure to fires are at increased risk of developing multiple myeloma.
My question is bone marrow biopsy the only way to determine?
So unfortunately, the answer is yes. So we do have to put a needle in the backside. But we, thankfully, it's a little bit easier than it used to be. But yes, that's really where the factory of the blood is. I mentioned the bone marrow. So the only way to truly diagnose, like we can do the blood tests, we find the abnormal protein in the blood, the antibodies in the blood, but to confirm it, it requires a bone marrow aspirate or biopsy, yes.
Since it is often confused with diabetes, are there any specific signs that we should look out for as, you know, as we age to be able to say more that it might be myeloma, multiple myeloma?
I love that question. So thank you for asking that. I don't want people to be afraid and thinking that, oh my goodness, I have diabetes, I could have myeloma. But at the same time, as someone is being treated with their diabetes, what I encourage people to say is, are we sure that all the symptoms and signs that I have, especially if it's affecting the kidney, especially if someone has the low red blood cell count, the anemia, because remember, we said myeloma was those 4 things of CRAB, a high calcium, that doesn't really happen much with diabetes. Renal or kidney damage, that does happen with diabetes. Anemia or a low red blood cell count, that also can happen with diabetes. And then bone disease, we don't see that as much with diabetes. But if someone says, oh, you know, your kidneys aren't working great, or there's protein in your urine, we think it's just the diabetes, it's a time to say, are we sure it's only the diabetes? Because sometimes they can coexist together.
My question is kind of like a piggyback on her question. The 3 things you mentioned was pain, fatigue, and anemia. So as we get older, we start experiencing some of this pain and fatigue. So what kinds of things that we should be looking out for?
Yeah, and that's the tough part, because we don't yet screen for myeloma like we screen for breast cancer or we screen for colon cancer. We're working on that at the IMF, and actually it may become a reality soon where, independent of symptoms, we just screen people who are healthy. But what I go back to is that notion that when that pain is beyond what you would just normally expect, Now, lots of other things can cause that pain. Lots of other things can cause that fatigue. Lots of other things can cause that anemia. But in medicine, we've learned, there are common things, there are horses, and then there are zebras. And what I'm saying is there are more zebras at this zoo of the diagnosis than sometimes doctors think of. Doctors think, oh, myeloma is so rare, it doesn't happen. But actually, it is more common. And as the population is aging, it is more common. So if you have pain that is more than the usual pain you experience, you have that fatigue that is more than usual, if a doctor discovers anemia, the good news is doing the testing for myeloma, yes, you need a bone marrow to confirm it, but to do that initial testing to decide if we need to do a bone marrow or not is just a blood test. It's not the usual blood test you get annually, so they need to do some specialized blood testing, but it is only a blood test. And so when there's a question mark, oh, I'm not sure if this is, that's the time where in conversation with your healthcare provider, you can say, should we be doing the testing for myeloma?
Well, first of all, Doctor, I want to say thank you for your bedside manners, your explanation, and your ability to speak to us in plain English. I love the red wine rosé and the white wine metaphor.
Well, that comes a little later, but
Yeah,
okay.
yeah.
I don't think Rosalind's serving that today.
Doctor, I think this is the right question for somebody who has the integrity and the honesty that you have shown us today. I'm big on holistic and natural medicine. And in my studies, it's been written, validated that the American medical system has co-opted synthetic medicine for profits, and that we don't talk about cures anymore. Then we look at the blue zones where Guam and certain parts of the Caribbean and the Mediterranean folks are living over 100, to be over 100 years old without the synthetic medicine. But yet, medical schools don't make the bridge and connection in teaching doctors about herbal, holistic medicines, yet the Bible speaks about everything we need is in the plants of the earth. So can you share with us your experience as it relates to holistic, natural medicine, or do you have to go find that yourself, or are you even into that modality?
Great question, and one that I could take a long time to answer, but I got to keep it brief. I'm actually, I believe, a very progressive thinking doctor, because I absolutely appreciate every day the limitations of what we're able to do. And I think for a long time, Western medicine has sort of buried its head in the sand of looking at more traditional and holistic things. I also have come to appreciate that the line between the physiological and the psychological is not concrete, that our bodies are a whole body, not just a collection of organs. And there's no doubt in our mind, we look at what's happening in this country, whether it's what we eat, the drugs that we take, the things that we get exposed to, whether it's processed foods or toxins released in the air, we've come to realize that these things are important to look at, that the answer isn't just a pill for everything. And I agree with you that we need that balance. That being said, I have witnessed thousands of patients who would not be with us today if it weren't for the synthetic drugs that we have created. So I always like to look at things in balance. You know, I live in Arizona. I run most mornings through the desert. And I sometimes put it this way to people. There are natural things that are great that we've not tapped into. There are natural things like snakes and scorpions that aren't so great. So I always encourage people to not think in this simple way of natural good, pharmaceutical bad. I think that's much too simplistic a way to approach it. But to recognize that there is a balance between the two of them. And that as we seek to take care of the whole of ourselves, our physical selves, our spiritual selves, our emotional selves, our psychological selves, we have not tapped into those things like you've quoted from the blue zones and others that involve exercise, that involve food, that involve a mental and spiritual state that so much of us are avoiding in this country. So I really do believe there's a balance. I've been given the please wrap up, and if I don't, then there's a cane that's going to come and pull me off the stage. So let me thank you. God bless every one of you. Appreciate it so much. Thank you.